with this said, it brings us to an important point which already we alluded to, which is really how do we stage the disease? If anything, we all agree that at the end of the day, HCC, as we suggested, is two problems in one: the cancer itself and the liver functionality disease related to probably a cirrhosis or something along that line. And understandably, we use different scoring systems, different staging systems. We are used to some of them, among which, for example, the Child-Pugh scoring, which really are 5 parameters to tell us about like how good the liver or how bad it is. But understandably, the 5 parameters of the Child-Pugh will lack the important parameters that are related to the cancer itself. It's really all the 5 parameters of the Child-Pugh are really related to the disease of the liver per se and not to the cancer. And as such, there has been a lot of efforts all over the world in regard to really get a better staging system. And I'll start by asking our colleague Dr. Masatoshi Kudo from Japan. So how do you stage patients in Japan?
Actually, in Japan, the BCLC stage is not so used, but sometimes it's useful because it's staged in combination with liver damage plus tumor burden and show the treatment strategy. So sometimes follow the overall we follow BCLC stage, but the prognostic prediction we use sometimes Japan integrating staging, G-score.
Sure.
And the treatment strategy, we have another, the JSH, Japan Society of Hepatology treatment algorithm guideline. So we follow those algorithm treatment guideline, and for prognostic prediction, different G-score. But the overall, the idea is, basic ideas like following the BCLC.
I hear you, I hear you, I hear you. And what about in Germany or in Europe?
I mean, it depends. I think from a clinical trial point of view, it's important to somehow categorize the patient into different categories. And the BCLC staging system is clearly most widely used, and I think we can all agree that we have early disease, intermediate disease, and advanced disease. From a clinical point of view, in daily clinical life, we don't really use it, because I think it's not really helpful, because what we have learned and what many trials have, or retrospective studies have shown, that, I mean, most patients are not treated according to the BCLC treatment algorithm. So, and this is also in our clinic the case, that in many instances, I mean, we have to see the pictures, we have to see where is the tumor, how is the liver function related, and the BCLC is nice, but for treatment decision, it's an oversimplification. It really needs the multidisciplinary tumor board, and therefore, I mean, to be really honest, we don't really use any staging system in a daily clinical life.
That's definitely quite fascinating to see those different point of views. What about, we'll ask Dr. Finn, like, what about at your practice? Like, what staging system do you use?
Yeah, you know, I take a little different take than Dr. Vogel. And it's very interesting, because if you look at the other cancers we treat, is there any such diverse opinion on how to stage patients? It's really very unique to liver cancer. And again, it represents the complexity of the disease. I think when we talk about stages, it's why do we stage patients, right? And from the cancer medicine standpoint, one, it is prognostic, right? You know, when I see a patient with these characteristics, I know what the natural history is, what to expect. And in that regard, the Barcelona criteria does that very well. And it's been developed out of the control arms of many prospective studies, and it does stratify patients very well, and it has become the benchmark for most of the prospective registration strategies. With that being said, and I think where Dr. Vogel and I and the others probably come to some consensus, is the orthodoxy in this stage, this is the treatment, right? And the treatments that are listed there, so there's the staging and then the treatment part, right? So the staging, I think, is very valid and is used in my practice and others in the United States fairly frequently. But also, you know, when it comes to assigning a patient to a specific treatment, that's where things need to be individualized, right? There's guidelines, there's research, then there's patient care and practice, which is what 90% of the real world does. So in that sense, someone might have Barcelona B, but is that strictly a taste patient, or maybe they'll get an RFA? And I think that's where the individual attention comes into play. The other thing for staging is not only for the patient in front of you, but when I'm reading a paper, I can compare apples and oranges, right? That if this study looked at an efficacy endpoint in Barcelona C, and this study did too, we can try to get a sense of some consistency.
I hear loud and clear. If anything, you will notice that actually for those of us who were involved in the field a while ago, like decades ago, one of the big debates that we used to carry on is at the time of even designing a study, which staging system shall we use? And if anything, you'll notice that ultimately we settled to the Charles-Pugh. If you ask me why, it really, for no reason specifically, short of that this is the only thing that we agreed upon and was the easiest to do per se. However, no doubt that we probably will differ in regard to what is the most pertinent staging system based on the etiology of the disease. And for example, we know very well that the QP, which is the Chinese University Prognostic Index from Hong Kong, is used among patients with hepatitis B, while the CLIP, the Cancer of the Liver Italian program, which is really based for hepatitis C patients, which is mainly used in Europe and probably is applicable in the US as well, because not only hep C, but also alcohol. And that's why we heard about the Japanese system, which probably is more hep C specific, more than there is any other etiologies. Now, what's interesting, however, despite all of that, the interesting part is that we're pretty much all coming to agree that the BCLC is a great method or a great kind of cheat sheet that you can have in your hands to tell you what to do for every patient. Small disease, we take it out. Small disease, bad liver, we do transplant. Locally advanced disease, we do some form of local therapy, etc., etc. And the fascinating thing is, however, and I think already I heard both Dr. Vogel and Dr. Finn brought up, which is very critical, is that the way the BCLC is defined is really very linear. It's from top to bottom. It's vertical. Like I have this, I do that. But interestingly, there is no connectivity at all in the BCLC between what if I have a patient with, let's say, locally advanced disease, but they become metastatic. What do I do? How do they move from one phase to the other? It's not even there. So I think it's a little bit more complex than that. And if anything, I'm happy to see that, yes, at the end of the day, it really depends on, as Dr. Vogel said, the multidisciplinary approach that will be very important to have the input per se. But I think we all acknowledge at the same time the necessity at least to assess how bad or how good the liver functionality is to make sure that we guide therapy accordingly.